Thank you for your participation in this exciting webinar. Our first presenter is Dr. Gregory Shears. Dr. Shears is a pediatric intensivist and anesthesiologist with a long-standing interest in reducing patient complications and improving our approach to vascular access. He completed his pediatric residency at St. Louis Children's Hospital, his anesthesia residency, pediatric anesthesia fellowship, and pediatric critical care fellowship at Johns Hopkins Hospital. He worked at the Children's Hospital of Philadelphia for 5 years and was recruited to the Mayo Clinic in 2001 to head the ECMO service. There he is a physician liaison to the nurse-led PIC team, medical director of the ECMO service, and co-director of the congenital heart unit. He is on the editorial board for JAVA and serves as the AVA Board of Directors as a director at large and recently chaired AVA's Strategic Planning Task Force. He's very active with product development to help reduce complications and has given hundreds of presentations locally, regionally, nationally, and internationally. Our second presenter is Patty Wilcox. Patty Wilcox is the nurse manager of the IV therapy team at St. Elizabeth Healthcare in Edgewood, Kentucky. She has more than 30 years of healthcare experience in the hospital setting. The IV therapy team provides multiple vascular access services, including peripheral IV starts, central line maintenance, declotting, and removal procedures. She and her team are part of the Rapid Response and Code Blue teams. She is Vascular Access Board certified and is actively involved in professional nursing organizations. She presented her research at the 2014 National Association of Vascular Access Conference. She's also presented at the 2015 Infusion Nurses Society Annual Conference. Our third presenter is Jeannie Zach. Jeannie Zach is currently a quality patient care consultant for BJC Healthcare. She is a graduate from Barnes Hospital School of Nursing, Maryville University, and the University of Missouri St. Louis with her PhD in nursing. She has held positions as a critical care and home health nurse, infection prevention specialist, and manager of infection prevention and occupational health. She also serves as adjunct nursing faculty at Webster University. Jeannie received distinguished alumni awards from the University of Missouri St. Louis and Goldfarb School of Nursing. In 2011, she received the Society for Healthcare Epidemiology of America's Advanced Infection Preventionist Award. In 2013, Jeannie was awarded the March of Dimes Nurse of the Year for her work in infection prevention and occupational health. She has consulted and spoken nationally and internationally about interventions to reduce central line associated infections and other infection prevention initiatives. Her work in reducing healthcare-associated infections using educational interventions has been replicated in Thailand. And now I would like to turn the program over to Dr. Shears.
Thank you, Bruce. Let me get my presentation up here. There we go. Hi, everyone. Thank you so much for providing this opportunity to be able to talk about near-infrared. I've been using near-infrared in my practice now for nearly a decade, and I'm honored to be able to provide for you some of the advantages of using near-infrared for peripheral vascular access. As part of my disclosures, I'd like to mention that I'm a consultant for Christie Medical Holdings. They're the maker of VeinViewer near-infrared devices. I also want to disclose that any of the non-referenced slides in my presentation are based on my personal experience and are my opinion. And lastly, and most importantly, I want to let you know that I am a firm believer in near-infrared. I hope that I can convince you as part of this presentation that this is an absolute must in your practice. I have found that it helps take me to an entirely new level of as a peripheral vascular access clinician. And I believe it's a necessary adjunct for vascular access. even if you're good at other things like ultrasound, it's a complementary technology that we really need to encourage people to use because it provides such an advantage to both yourself and to the patient. So some of the objectives I'm going to cover during this brief time include discuss the importance of near-infrared technology to the clinician and how it can help advance practice. Describe directly some of those advantages, and lastly, identify how near-infrared can be very useful for many of today's vascular access challenges. So, why is near-infrared so important to me as a clinician? It's important to me for several reasons. One, it takes me way beyond what my eyes can see and fingers can feel. So I began doing peripheral vascular access way back in my pediatric residency, and I have from the early '80s when I was really developing my skill set. This was before we had IV teams and other things, at least within my children's hospital. I took it upon myself to get really good at it, and I was honing my skills and also looking for ways to get better. And it was very easy to see that my skills were limited. And that's something that's been a problem to our entire specialty, is that we're sort of stuck. When we only have our eyes and our fingers, we can only be so good. And so allowing this technology can take me beyond that, and it really gives me an edge for the clinician, an edge for the patient. Secondly, it helps me get closer to that one stick, one access. Now, we all know this dirty little secret that, even in the best of hands, the real ratios are about 2 sticks to 1 access. And we also know that that ratio is much more off, 3, 4, 5, 14. You can see those reports in the literature. Well, I find because it gives me additional information to make me a smarter peripheral access clinician, that I get much, much closer to that one stick, one access approach. It's better for me, and it's way better for the patient. Closer to one stick means less pain. It also means, for me, less time. So it's a win-win. And consequently, this together makes me more efficient. It allows me to be more efficient because I'm much faster identifying sites that are reasonable targets. It allows me to achieve access faster, and then I can go on to do the other million tasks that I have to do. So it really, it helps me so much. And all of these things and many others that I'll talk about somewhat in this presentation, it makes me better than I am without. I mean, it's like night and day. It gives me such an advantage that it really makes me look good as a peripheral vascular access person. There's no comparison. Without it, I am at such a disadvantage. So many of you, or maybe all of you, work in places that you're dealing with patients with chronic illness, and they're coming back to you regularly. Same thing with my practice. I get a lot of patients coming back for various treatments who have long-standing illness, etc. And they are very quick to point out when I'm using near-infrared on them, and they may have been a 2, 3, 4 stick kind of person before, and when I get that access right away for them, they say, wow, this is amazing. How come everybody doesn't use this? And so it's nice to hear that people that know that the naive patient that's being stuck first time, some of them put up with it because they don't know any better. We have a problem. We have uninformed consumers. Those people that know see the advantage, and I've got so many compliments from these quote-unquote frequent flyers that are just so happy to have the added benefit of this technology to reduce their sticks. All of this and many more things help provide tremendous professional satisfaction. I must say I had some very low points when I was back in my pediatric residency days, and I was learning how to do access, particularly on children. It is rather depressing to miss repetitively on small people, especially when they don't know any better, and to be able to now take those years of experience, take the technological advantage and deploy it on patients and get access quickly and easily. I mean, you don't feel any better than that by helping somebody. It's just a tremendously satisfying process. So why is NIR infrared important to the advancement of venous access? Let's face it, peripheral venous access has been relatively stagnant with regard to progress. Much of what we have been doing is the same stuff that has been going on for the last 40 or 50 years. We have this stick and run mentality, and it's not that clinicians are bad people. It has to do with the fact that, one, there's a big knowledge gap, and two, people don't realize that there are better approaches. And so we've got to get out of this. We've got to get out of this stick and run type of mentality. We need to prospectively manage peripheral vascular access. We need to think of it as a resource, and we need to protect that resource. We need to avoid, stick. Okay, maybe we'll call the PIC team now because we've run out of options. No. We need to learn to assess these patients up front. We need to understand what kind of options they actually have, create a plan, understand what it is, the therapeutic process that they need to go through, and then deploy that option. And if it's peripheral vascular access, great. Do that. And do it smartly. Pick a good vein. I'll talk a little bit more about that in a while. You can only see and feel so much. You feel a bulging vein underneath the skin, or you might see it because it's up on the skin. But you can't really tell where the valves are. We often can't determine where the tortuosities are, where the bifurcations are. Near-infrared can help you do this. Consequently, you can strategically place your catheters. You can put your tips of your catheters where you want them to be by properly planning and identifying optimal sites. So near-infrared gives a huge advantage that way. I bet if we start deploying it in that way, we will reduce peripheral catheter-based complications because we will increase our success by avoiding valves and other things, and two, we will prolong dwell times because we're not going to be bumping up against a tortuosity or a valve or being up against the bifurcation. So I think this is all obtainable within the range of the technology that we have today. What has happened to our specialty is that there is a pervasive complacency, and we have been undervalued. We have been grossly undervalued. Let's face it, peripheral vascular access is the core of 80 to 90% of all of healthcare. We should be near the pinnacle. We should be very important, and yet we are pushed down. The IV teams are undervalued. They're being dismembered. The teams themselves are being taken apart due to financial concerns, not understanding that the value that they bring, the enhanced patient satisfaction that they bring, the importance of an educating vascular access person to improve patient care, since we're involved in essentially all of inpatient care. We got to shake ourselves. We got to shake the medical community, get out of this complacency, value vascular access clinicians the way they should be. Near-infrared and ultrasound are helping to change this. Yes, ultrasound too. So you can't be a state-of-the-art, sharpshooting vascular access clinician unless you have a working knowledge of near-infrared and ultrasound. They are complementary technologies. If you really want to have the depth and breadth, what you need to be a full-fledged vascular access consultant, you need to embrace these technologies, get really good at them, and deploy them on your patients. I guarantee you, you will be very happy, and you will help raise the bar on peripheral vascular access. So what are some of the advantages? There's so many. I'm just going to touch on a few. The ease of performing vein assessments, being able to provide more access options, the process of obtaining venous access, a no-touch approach to peripheral cultures, and lastly, solving clinical venous problems as your maybe post-accident. So how about performing vein assessment? Well, here's a lady that I was asked to put a catheter in. And, you know, at first blush, you come to her, you put on the tourniquet, and you just can't see a thing. I mean, there's just nothing there. And what would that mean under normal circumstances? You know, I'm palpating everywhere, I can't find anything good, I can't see anything good. It would likely lead to blind sticks and pain, maybe going to find the ultrasound. So a difficult situation. So how can we do a better job with this whole process? And I'm going to come back to this issue of pre-access management as a necessary part of all vascular access. This requires us to act not as stick-and-run people. This requires us to step back and be the consultants that we are. We need to get to know our patients. We need to review their medical history. We need to understand the prior vascular access history. We need to look at what is the treatment regimen that is intended. What are they going to get for infusate? What is the likely catheter dwell time that's needed? Then we need to, if peripheral access is the right thing, we need to determine the best vein, not a vein. It's not just let's get it, let's get out of here. No. Let's try to pick the best vein. Let's think about what the CDC said about, you know, we can have 96-hour or longer dwell times. Well, we can't do it most of the time because we can't get optimal veins. So let's determine the best vein. And not only that, with the help of near-infrared, let's pick the best section of the vein. So here's this same lady, and I'm getting out the near-infrared device and scanning her very quickly. She's got all kinds of options. I'm going to show you the back of her hand in just a little bit. Now, I mean, she doesn't have big bulging veins to the normal eye, but with the help of near-infrared, she's converted from a difficult vascular access person to somebody with many options. And you just now have to decide what is the best option. Here's the back of her hand. Again, very difficult to see anything or palpate anything. But you put on near-infrared, voila, you've got a completely normal vasculature under her sub-Q. And so, again, you turn a difficult vascular access patient into an easy access patient with lots of options. Now you pick and choose the best vein, you pick and choose the best site on that vein, and you set this person up for a reduced likelihood of complications during her need for vascular access. So, creating a peripheral IV pre-access plan, choosing that optimal site, avoiding bifurcations, T's, cul-de-sacs, identifying valve locations. You can't do it any other way. There is no other technology with which you can do this easily. I've tried to use ultrasound to do this. It's impossible. It takes too long, and the person gets greased up from head to toe. It just takes forever. It's too slow. Near-infrared is the only technology that I have found where you can quickly do this sort of assessment. You can also very quickly identify if there's been old catheter sites of thrombosis within the vein. And also you get a sense, after you've done this for a little while, understand what the venous flow patterns are like. I suspect that in the future we'll be talking about identifying veins with X amount of flow, the rapidity of flow as we're putting in our medications, as opposed to sluggish ones. And I'm going to actually show you some examples of this in a little bit. So another advantage is more options. Near-infrared, hands down, provides more options, consequently allows you smarter choices. So there was an initial pilot study done looking at the pediatric patients, and it found a substantial increase in the number of options. This was in excess of about 310% of usable veins. There was also a formal study done by the University of Rhode Island and Hasbro Children's Hospital that was published and presented at INM. And they demonstrated, this was done by sharpshooting peripheral vascular access people, and they found also a significant improvement in the number of options for both adults and pediatrics. And because of my limited time, I don't have a lot of time to show you many things, but there was a substantial increase, even in the hands of these delving vascular access folks, a substantial increase in the number of venous options that were available with the help of near-infrared compared to what they could see with their eyes or feel with their fingers. Another really important concept that's evolving and we're trying to get our hands around is putting in the right size catheter in the best vein. This is not a very easy thing to do unless you have a weightlifter or incredibly skinny person where they have a vein laying up on the surface. So for most patients, this is essentially an impossible task or very difficult. And one of the nice things about many of the near-infrared devices out there, particularly a couple, the back projected image on the skin is exactly the width of the vein underneath the skin. So these companies have gone through great pain in order to precisely get the algorithms correct so that what you see is what you get. Consequently, you see that vein painted on the skin, you can lay your catheter down just like so, and you can look at it. And the current thinking is that the ratio, the external diameter of the catheter should be no more than about a third of the vessel size if you're looking for, allowing flow around the catheter and reducing the activity thrombose. What about avoiding valves and other hazards? Well, this is a breeze with near-infrared. What you do is you occlude it distally, you milk the vein, you'll find a valve always, you identify where that valve is, and now you can avoid it. There's no other way to do this. It is impossible. The problem with now learning this technology is you're never going to be able to use the excuse, oh, there's a valve, in terms of advancing your catheter because you're always going to know where they are. The other thing you're not going to be able to do anymore is you're never going to be able to say, oh, the vein moved or the vein rolled. You're always going to be able to see where the vein is going. So we have to get rid of our excuses of missing our access because of those things, because now you see it. Okay, here's another lady, and I'm just milking the vein, and you can't, I'm going to tell you, you cannot predict consistently where those valves are. Here's just an odd insertion of the valve. I would have expected that the valve was going to come off on the other side of that other vein, but no, it didn't. So it's important to know this as you're planning for that optimal site in order to prolong dwell times with your peripheral IV catheters. What about using it for achieving venous access? Yes, this is one of the core advantages of near-infrared. This is a guy, his BMI was in excess of 40, and he told me before I started that it always takes 3 to 5 sticks in order to get access. He just about cried after I got access with him because it was one stick, very easy. Again, I looked all over. I couldn't see anything obvious with my eyes or feel with my fingers, but with the help of near-infrared, boom, one stick, I'm done, moving along, going on to other things. I also optimally positioned the catheter so I could avoid the valve just distally to it. This is another guy. He was very thin, but said that he was a difficult access patient, and he was. I couldn't see anything. And thanks to the use of near-infrared, boom, I was able to get it right away, one stick, and again, really happy person. There's been a lot of research being done in the recent years around using near-infrared. This is a nice prospective cohort study done by Holly Hess, looking at patients that either used a near-infrared device or control. And what she had found is that there was a significant increase in first stick success rate using the device compared to just the standard eyes of palpation. Also, there was a substantial reduction in the number of stick attempts per patient. Here's another study. This one was from Korea. The device translates. These problems exist all over the world. Everybody is having peripheral vascular access issues. And this group did a prospective randomized trial using the near-infrared device versus not. They also incorporated Kenyan DIVA score as part of distinguishing easy versus difficult patients. And what they found, I think, was very predictable if you know anything about using near-infrared or have any experience. If you're looking at an advantage to the stick success with patients that are easy, i.e. you can see the vein before you with your eyes readily, there's no advantage to that part of it. It gives you other advantages for those veins, like where the valves are and things like that. Hence, the two columns are with the device and control are the same. But for difficult vascular access patients, a huge statistically significant difference between the two groups. Here's another study. This was from Taiwan, prospective randomized study looking at two groups using the device versus not. And they found a number of things that I found in my practice as well. The mean time to find the first available vessel was shorter. The first attempt success rate was lower. The number of attempts were lower, and the total time for attempts lower. So just like with them, the device has helped make me more efficient. It helps reduce my number of sticks. I spend less time looking around for a good vein. What about other options, such as you're trying to work up a patient with a CLABSI, they have a central line, and you're asked to do a peripheral culture. Everybody knows nowadays, the CLABSIs are with regards to CMS, some of the never should happen things. And consequently, false positive blood cultures have a big negative impact. If you have a false positive blood culture, that could mean lack of reimbursement for that period of care that you're providing. So it's not uncommon, in my experience, that you palpate, you think you can find a vein, and you get the needle, you prep, you get the needle in the skin, and then you can't find it. You can't seem to enter into the vein properly, or you get a little bit back and you can't give additional blood. Well, near-infrared helps you be strategic about this. It helps you look at what is the actual angulation of the vein so that you're more apt to hit within the lumen. And consequently, you don't have to touch, you don't have to move the needle around in a singer-sewing method to find the vein, and it helps you with problem solving. And I'm going to show you some additional examples of this. So, with regard to where are the valves, this is a cartoon that helps us kind of look at what a valve is like, how the slabs of tissue are, how they hold the blood back. This is a histological section, and you can see the valve there in the center of the screen and the blood held up behind it. This is a valve that I found within a jugular vein. Occasionally you can find those there. Now, I ask you, if you're really, really good with ultrasound, you go and try and find peripheral vein valves. It took me 30 minutes to get this image. The main vein is going in and out of the screen in the upper center, and then there's valves coming in on the side. It is very difficult to do that, to get an image like this. Consequently, it's clinically impractical to do it. There they are. So, very commonly, if you're trying to pick an optimal access site, we see part of the vein like in the lower part of the screen, but we don't see this. We don't see the tortuosities, we don't see the valves, we don't see the bifurcation. So near-infrared helps you see those things and helps you avoid positioning your cannula up against the sidewall where there's tortuosity, or going through a valve or up against the bifurcation. Consequently, I believe if we start using this in this way, we will be able to help reduce some of our complications. So here we have a gentleman who's got a beautiful straightaway of a vein. And because of near-infrared, I know exactly where the valve is. I know that I've got a great straightaway, and I'm going to enter in on the lower part of that little rectangle there, near the beginning of my left index finger, and I'll be able to position my catheter well away from that valve in a straightaway, and if it's properly secured, compared to another vein that maybe, the tip is randomly positioned, I bet that the dwell time will be longer. have you ever had it happen to you where you palpated a vein, you stick, and you can't get it, just like this blood culture example? Well, with near-infrared, you can see where the vein is. You can watch how it moves in case you didn't get it dead on, and you can adjust your angulation of your catheter in order to bias towards striking it directly. So here's some other interesting problem-solving things. Have you ever tried to draw blood from a catheter and all of a sudden it stops? Well, what is the first thing you do right after that? A lot of times I've started to move the catheter thinking that it was, up against the wall, or it would somehow improve my filling by doing so. Well, some of the times I've lost my catheter or I've caused a hematoma in the process. Well, watch very carefully at this vein and notice how it's flushing. Why is that? Because I'm drawing blood faster than that vein is being refilled, and there's a valve just distal to it, so that now, if I'm watching this while I'm drawing, I know exactly why the blood flow has stopped. It's not refilling fast enough, and actually I made a mistake. I put too large of a catheter at this stage. I should have put a 22 instead of a 20. And so it's not refilling very quickly, and the valve is preventing that other blood from coming back and draining into that vein. So now I know I've got to go a little bit slower. When it stops, I've got a helper. I'll pass off the syringe to somebody else, let it refill, and then draw some more with a second syringe, because I know my catheter is just fine. The problem is slightly too large of a catheter in the vein, and it's just not refilling fast enough. Here's another interesting example. I did access on this gentleman, and I didn't get any blood back. Everything, from a tactile standpoint, it felt good. I thought I was in for sure. And so I was a little bit confused by this. So I got out my near-infrared, and I put a saline flush on the catheter, and I pushed some saline. This one doesn't show through very well, but the column of blood is moving forward distally. So the catheter is in, and what's happened with this gentleman is he had a profound vasoconstriction event. So what I did was, instead of what I would typically have done, walk away, I didn't walk away, I would have normally removed the catheter and stuck him again, because I would have declared that a bad shot. I hooked him up to IV tubing and walked away, and came back 15 minutes later, and his vein was fully open and the venoconstriction had gone away. So it was a perfectly fine catheter placement. It's just that he had constricted around the tip and that there wasn't any blood flow back. So the other thing that near-infrared does is it tells you when you make mistakes right away. Look at how quickly you see that flush of blood outside of the vein. It just, it shows up immediately. It becomes very obvious that there's blood where it shouldn't be. It may also help us with reducing extravasation injury. So unfortunately, extravasation injury has become amazingly common. And if you look in the literature, you see it up to about 26% of the time. So if you use near-infrared during flushes immediately after placement or prior to the administration of medications, like in this example, you can do small boluses of saline and watch that column of blood moving forward to give you some sense that the catheter may be in the vessel. So you do have to take the dressing off and whatnot as you're doing it, but it could be potentially helpful for you in evaluating your site. So in summary, I've found near-infrared to be just a huge advantage for myself, and consequently, it's going to be a huge advantage for any clinicians that really embrace its use. You get way more information than you can with your eyes or your fingers, and consequently, it's going to allow you to make better decisions. It is the ideal tool for pre-access assessment. There is nothing else out there that allows you to rapidly assess what patients have with regard to peripheral venous access options. It allows you to do real-time problem solving, and all of this is going to result in better care for patients. We need to help take peripheral vascular access to the next level, and near-infrared and ultrasound are going to help us get there. We need to embrace these technologies, use these tools as a normal part of our everyday care, and as a consequence, we are going to improve patient satisfaction. And that's what this is all about. This is about patients doing a better job. So I want to thank you very much for your attention, and I also want to mention that the INF has recognized the advantages of near-infrared, and they've put out a position paper suggesting that we should increasingly use vein visualization technology to improve our practices. So, and this is just an example of the position statement that they have. And under number 9, they say incorporate vein visualization technology as a routine strategy for patients with difficult or poor venous access, and that visualization technology can improve success rate, decrease unsuccessful insertion attempts, and improve patient satisfaction. So thank you all very much for listening in, and I want to turn this over now to Patty Wilcox.
Thank you very much, Dr. Shears. Okay. Let me come back and try to share my screen again, please.
We can see your screen, Patty, so you'll just need to pull up your presentation.
Okay, I cannot see it.
Down at the bottom there. Click.
Okay, gotcha. Okay, here we go. I am here to talk about the implementation of near-infrared technology to decrease PICC line placements on patients with limited venous access. As far as the learning objectives are concerned, I would like to define the patient population that would benefit from the implementation of near-infrared technology, to describe the process of near-infrared technology, to explain the difference in near-infrared technology depth visualization as compared to ultrasound, to discuss the outcomes that resulted from the implementation of our near-infrared technology. As far as the background is concerned, it was identified that a significant number of patients were requiring PICC line placements due to poor venous access at our institution. So my IV therapy team and I realized that this was an issue with our patients and were looking for a resolution. I would like to give you 2 examples. The first example would be our patients who, say for instance, were admitted for hydration or for non-vesicant medications that did not meet central line criteria. And the patient's peripheral access was so poor that sometimes they were requiring central line placement or PICC placement to receive their treatment. A more extreme example would be very few, thankfully, but say, for instance, we had a patient who was in for an outpatient procedure, an endoscopy procedure, and the patient had such poor access that my IV team and I were unable to obtain a peripheral IV start for their procedure. So the patient, unfortunately, required going down and having a PICC line placed, having their procedure done, and then the PICC line removed before they were discharged. And obviously we recognized that this was an issue and wanted to do better for our patients. So, research was initiated to investigate vein visualization technology with the goal of improving peripheral IV success rates. So the purpose of the healthcare delivery process improvement was to implement the VeinViewer technology to improve our peripheral IV placement rates, to reduce PICC line placements on patients with limited venous access that did not meet criteria, to preserve the peripheral vasculature for possible future fistula placement, reduction of unnecessary PICC placements, which decreases possible associated complications such as thrombosis and central line associated bloodstream infections, which is a very important focus. So, the project description. Basically what we did, the near-infrared vein visualization technology was chosen. To tell you a little bit about it, it projects the near-infrared light, which is absorbed by the blood, reflected by the surrounding tissues, and projects the image of vessels on the patient's skin. Near-infrared technology allows visualization for approximately up to 1 centimeter as compared to deeper visualization with ultrasound technology. And our goal was to place our peripheral IVs in the more superficial vessels so that we could preserve the deeper vessels if the patient did require future fistula placements. Equipment and training, so what we decided to do was we bought a portable near-infrared unit for each member of our IV team to have on their supply cart with them at all times so that we could use it on all of our patients. And the training for the IV therapy team was implemented. I would like to add that the training really was not that complicated in itself. The near-infrared unit is very easy to use. Once you kind of get the basic instructions, what we felt that took us more time for our team was to use it effectively, meaning for the team to be able to realize, as Dr. Shear said previously, how effective it is in picking the proper segment of the vein and for avoiding bifurcations and valves. So our results, the data comparison began in January of 2013, and we compared the total number of PICs placed in 2012 prior to the implementation of the near-infrared technology, and we compared it to 2013 and 2014 after the implementation of the near-infrared technology. The results of the data comparison we felt were significant. 340 less PIC lines were placed in 2013 as compared to 2012, and the following year, 339 less PIC lines were placed in 2014 as compared to 2012. And you can see those numbers are identical, almost identical, 1 digit off. So the results represent a decrease in PIC line placements of approximately 21% per year. This data graph shows the information that we had, and it compares 2012, 2013, and 2014. Basically, 2012, you can see, is the red bar. 2013 is the black bar on the graph, and 2014 is the gold bar. And the numbers, total numbers down here are included. In 2012, 1,612 PIC lines were placed. 2013, 1,272 PIC lines were placed. And then in 2014, 1,273 PIC lines were placed. So as far as implications are concerned, we had a significant decrease in PIC line placements. We definitely have increased patient satisfaction, cost savings, and vessel preservation for our renal patients and for all of our patients was achieved. So in conclusion, the implementation of our near-infrared technology led to increased success rates for peripheral IV starts, decreased PIC line placements on our patients who did not require a PIC, and due to criteria purposes, and then definitely vessel preservation. And now, at this time, I'd like to thank you all very much and turn this over to Jeannie Zach.
Thank you, Patty. So my presentation today is about value-based purchasing, the real cost of central line-associated bacteremia, or CLABSI. This is my slide for disclosures. So what is the background? The Affordable Care Act was signed into law in March of 2010. Together with the Healthcare and Educational Reconciliation Act amendment, the Affordable Care Act represents the most significant regulatory overhaul of the U.S. healthcare system since the passage of Medicare and Medicaid in 1965. The Affordable Care Act was enacted to increase the overall quality of care and reduce healthcare costs for individuals and the government. Built on hospital inpatient quality reporting, Congress authorized inpatient value-based purchasing in Section 3001A of the Affordable Care Act. The program attaches value-based purchasing to the payment system that accounts for the largest share of Medicare spending. This affects payment for inpatient stays in over 3,500 hospitals across the United States. Participating hospitals are paid for inpatient acute care services based on the quality of care, improved patient outcomes, and innovations in patient care. Payment is not awarded for the volume or the quantity of the services a hospital provides. So I really like this slide by Don Berwick. Instead of payment that asks, how much did you do? The Affordable Care Act clearly moves us toward payment that asks, how well did you do? And more importantly, how well did the patient do? For those of you who do not know who Don Berwick is, I think of him really as a quality guru. He was the president and CEO of the Institute for Healthcare Improvement, the IHI, for over 20 years. You may have heard of some of his quality work with the Saving 100,000 Lives campaign. He invited hospitals to participate in the 100,000 Lives campaign, and of course, hospitals signed up, committing to save 100,000 lives. He is also a physician and was chair of the National Advisory Council for the Agency for Healthcare Research and Quality. In July of 2010, he was appointed by President Obama to the position of the Administrator of Centers for Medicare and Medicaid Services. So what is value-based purchasing? Value-based purchasing is part of CMS, the Centers for Medicare and Medicaid Services' long-standing effort to link Medicare's payment system to a value-based system to improve healthcare quality, including the quality of care provided in the inpatient hospital setting. Medicare launched a program to reward hospitals that were providing exceptional care for patients in their facilities. This exceptional quality of care really is rewarded through this new hospital value-based purchasing program, which is paid under the Inpatient Prospective Payment System, IPPS. Paid under the system, the quality of care is provided to patients is to be rewarded. Quality rewarded, not the volume or the number of services a hospital provides for a patient. So if you're buying a car, there are dimensions of quality that we as consumers expect. We expect safety, we expect fuel efficiency, we expect comfort, a car that is fun to drive. We expect the car to be durable and not to break down or have recalls. We research the internet for our cars, check consumer reports, we talk to our friends. We demand the best in quality and efficiency. As consumers, if our expectations are not met at one dealer, we will go to another. We will take nothing less. But what about the dimensions of goodness in healthcare? Do we put the same amount of time in researching our healthcare as you do with your next car? I would have to say, from talking with patients, families, and friends, we do not put forth the time for this extensive research regarding our healthcare. As expenses continue to grow with expensive medications, supplies, and labor costs, and then with some patients being readmitted with post-op infections or negative outcomes related to their previous hospitalization, costs and mortality are adding up, and the government is saying we will not pay for these negative outcomes. So hospitals now have financial incentives put in place by the government to ensure patients receive the exceptional care, the goodness in health care, or be penalized through withholding payments. So let's take a look. This table shows the value-based purchasing priority weighting. There are five weightings listed in this table. Under the percent program contribution, you can see the following listed. You have the process of care, outcome, patient experience, which is the age caps, your safety and efficiency, and cost reduction. Safety is actually, you can see, for safety, is really focused on 2017. The patient safety indicators under the safety component are also broken out into domains of 1 and domain 2. Under domain 1 are the patient safety indicators, or the PSI 90s, and I will talk about that in a little bit. There are also, under domain 2, is the PSI is also the central line-related infection for catheter bloodstream infections. So this metric for central venous catheter-related bloodstream infections actually resides in two domains, domains 1 and 2. The federal rule defines how much each domain is weighted to calculate a total performance score. The total performance score is then translated into an incentive payment, where a portion of the base DRG payment is contingent on hospital performance. Based on performance, hospitals can earn an incentive payment. So where do the incentive payments come from? These monies come from the percent of program contribution. For example, 1.50% in 2015 is now up to 2.0% in 2017 and continues at 2% for succeeding years as a percent of DRG payments to eligible hospitals. This percent is withheld to contribute to the estimated $1.4 billion necessary for program incentives, for quality program incentives for hospitals. CMS is then required by law to redistribute the monies paid into this hospital program back to all participating hospitals. This is based on the hospital's performance score. The IPPS document was just released, finalized for federal fiscal year 2017, Value-Based Purchasing Program. If you remember on the last slide for federal fiscal year 2017, the percent contribution is 2%. If our incentive monies are based off of the performance period for PSI 90, and this performance period ended June 30th of this year in 2015, just a couple months ago, the CLABSI measure, the performance period, will end in December 31st, 2015. Intervention work today to reduce central line-associated bloodstream infections will impact federal fiscal year 2018. So how do hospitals receive points? Each hospital may earn two scores on each measure. One is for achievement and one is for improvement. During the performance period, the points are awarded by comparing an individual hospital's rate with the threshold. The threshold is a median or the 50th percentile for all hospitals' performance during the baseline period. And the benchmark, which is the mean of the top decile, or approximately the 95th percentile during the baseline period. For example, the hospital rate is at or above the benchmark. The hospital received 10 achievement points. If the hospital is below the achievement threshold, they will receive 0 achievement points. Improvement points are awarded by comparing a hospital's rates during the performance period to that same hospital's rates from the baseline period. If the hospital's rate is at or above the benchmark, 9 improvement points are awarded. If the hospital's rate is at or below the baseline rate, 0 improvement points are awarded. If the hospital rate is between the baseline rate and the benchmark, the hospital can receive 0 to 9 improvement points. The final score awarded to hospitals for each measure is the higher of these two scores. So this is the HAI scoring based on hospital performance during measurement period compared with the national performance during the baseline. So this is the second half of the domain. This is actually domain 2. Any points hospitals must be above the average or show some improvement to score any points. There are 8 measures that comprise domain 1 weighting. Today we are discussing PSI 7, central venous catheter-related bloodstream infection, or CLABSI. The CLABSI metric is found not only in domain 1, but it's also found in domain 2. Weighting percent is 6.5% in domain 1 and 33% in domain 2. So you can see that actually to get all your 35%, you actually have to have better scores in the weighted period for each of these metrics. The evidence has shown that CLABSI increases hospital length of stay by 6 to 10 days. There is also associated costs with CLABSI. The non-inflation adjusted cost of central line associated bloodstream infections varies from $3,700 to $29,000 per episode, but I have seen costs associated with CLABSI to be upwards of $46,000. For example, a patient that stays in the hospital longer and the DRG payment for this hospitalization was only going to cover 3 days. So you have 3 days added on to what will not be paid for the payment withheld from the PSI 90 composite, and also the CDC healthcare associated infection, because it really goes to both domain weightings. And now CLABSI is counted twice. You have a double impact. The bottom line is that unless the hospital reduces central line associated bloodstream infections, hospitals will lose money for reimbursement from CMS. I would be remiss if I did not share that not only will hospitals lose CMS payment, but insurance companies like Blue Cross Blue Shield, Anthem are not going to pay for poor hospital performance either, and other insurance companies are getting on board. So maybe you are thinking, we have a small Medicare population, it will not affect us as much as hospitals whose payer mix is strongly Medicare. Wrong mindset. We must do everything we can to reduce CLABSI. I share with my hospitals that we should strive for zero. If we do not strive for zero, hospitals may close because they will not have enough money to staff their facilities or obtain the latest technologies. Patients also may choose not to come to your hospital as infection rates are reported and available to consumers on Hospital Compare. So you are thinking, how can my facility reduce central line associated bloodstream infection? So there are numerous evidence-based practice guidelines that are available from the CDC and also from the Society for Healthcare Epidemiology of America and the Infectious Disease Society of America to reduce central line associated bloodstream infections. So first of all, you remove non-essential catheters, which is A-2, and I'm not going to read all the details under there. You can read those yourself. Also, promptly remove any intravascular catheter that is no longer necessary, and that is a Category 1A from the CDC, which Category 1As, as you know, are strongly supported and have lots of evidence and well-designed studies to support them. If the patient still needs access but does not need a central venous catheter for medication, the nurse can insert a peripheral venous catheter, and this way the patient is not exposed to getting a central line associated bloodstream infection. So what is the real cost of CLABSI? You have longer length of stay for patients, anywhere from 6 to 10 days. And remember that the insurance companies and Medicare are only going to pay what the DRG for that hospital admission is. So if the patient came in for a surgical procedure and develops a central line infection, they are not going to pay for that central line infection. And also you have costs associated with that non-payment up to about $46,000 for that central line associated bloodstream infection. So there's reduction in reimbursement from CMS twice. And as I stated earlier, most likely insurance companies will follow the government and not pay for these poor infection outcomes. Also, getting an infection is a big dissatisfier for patients and their families, so this could affect your HCAP scores. So in conclusion, evidence-based practice guidelines for CLABSI have been around for more than 15 years. Quality-based reimbursement impacts the bottom line for all hospitals. And value-based purchasing is about quality care and not the volume of care or the number of services we provide per patient. Our patients expect quality care and never expect to get an infection during their hospital stay. Our patients deserve, and let me say it again, our patients deserve exceptional, excellent care and zero infections. They are our consumers, and more importantly, they are someone's mom, son, grandparent, or best friend. Thank you.